Hey, I'm Chris, and this is my Cardioversion checklist OSCE for ILS 2018. We've been called to a 65-year-old male patient by the name of Steve. He has a chief complaint of chest pain and has had a collapse. His history of myocardial infarction approximately 6 years ago. When we arrive on scene, he appears pale and clammy with a GCS of 12, consisting of 3 for eyes, 4 for verbal, and 5 for motor. He had a near syncope and he's feeling dizzy at the moment. We're going to lie the patient on the ground and do a full assessment. So with Steve now on the ground, we've attached our 12 lead and we've got a rhythm strip. On here it appears that we have a wide complex tachycardia at approximately 160 beats per minute. When we feel for a pulse, we note that we do have a carotid pulse, but we don't have a radial pulse. It is important to consider differentials for VT so that we can rule out SVT with aberrancy, either due to a bundle branch block or Parkinson-White syndrome. On the 12 lead, we note that we have precordial concordance and that we have extreme axis deviation. Steve is old and has extensive cardiac history, so these signs are all indicative of VT. So with this information, we're going to go ahead and call for backup and prepare for a cardioversion. AET1 calls control.
Go ahead.
We've got a conscious VT patient here, status 1, requesting R50 backup, please.
Alright, we'll sort that out for you.
Cool, thank you. Backup en route. We want to determine the level of cardiovascular compromise. We'll obtain a full set of vital signs. Having obtained this information, it was found that Steve had the abnormal vital signs of a blood pressure of 70/40, a heart rate of 160 beats per minute, a rest rate of 10 breaths per minute, a capillary refill time of 3 seconds, and an SpO2 of 88%. Well, with this information, we're going to attach a high flow oxygen with a reservoir mass of 10 litres per minute. And I'm going to go ahead and listen to his lungs. Upon auscultation, it was noted that Steve had widespread crackles. This is indicative of cardiogenic pulmonary edema. There are 2 forms of cardioversion. These are electrical and mechanical. As Steve is severely compromised due to severe hypertension, he's unable to obey commands, and he appears status 1, we will go with the electrical route. For sedation, we potentially may need an ICP to administer ketamine. As Steve is unable to obey commands, we won't need that. If we were to do a chemical cardioversion, we would also need an ICP backup to administer amiodarone, as this is out of our scope. We have bilateral IV lines in here, just in case we do need that ketamine. And on the side here, we have our resus equipment, so our bag valve mask, our LMA, MPA, and OPA airway adjuncts, and high flow oxygen. We want this equipment just in case our VT deteriorates into VF and causes cardiac arrest. Done. We can go ahead with our cardioversion checklist. I'll get my offsider to read this out to me, and I'll go ahead and check off the components of that and relay the information back to him. So I'm just going to go around to the head here, just so I'm not reaching over the patient, and I'm maintaining cultural sensitivity. Jake, can you go ahead with the first step, please?
Place pads in either the apex sternum or anterior-posterior position, in addition to ECG electrodes.
Okay, so I'm attaching the pads here. We have our 12 lead already on, as we've got that on before.
Ensure the defibrillator is in manual mode.
Okay, we've got it on manual mode. We put it into manual mode before.
Select a lead with a visible R wave and ensure that artifact is minimized.
Okay, selecting lead. Looks like lead 2 has good visible R waves, and there's a little artifact.
Select synchronize mode.
Okay, sync.
Confirm there is a detection symbol above every QRS complex.
Okay, yep, we have a detection symbol on every QRS complex. This is important to note as we don't want R on T, as this can cause cardiac arrest or torsades.
Ensure the patient has received adequate sedation if indicated.
In this situation, sedation is not indicated as he is unable to obey commands.
Select the joules, charge the defibrillator, and confirm everyone is clear.
Okay, so we've got our max joules at 360. I'm going to go ahead and charge. Everybody please stay clear of the patient.
Press and hold the shock button until the shock is delivered.
Okay. Everybody please stay clear.
Determine the rhythm and the level of cardiovascular compromise.
Okay, so we'll print off another rhythm strip and have a look at that. So we still have a wide complex tachycardia and VT. I'll check for a pulse. I still have a carotid pulse, but I have no radial pulse.
If administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
Okay, so if we were to deliver a second cardioversion, we'd also reassess the ABCs and get another full set of vital signs and do another pulse check. Then we'd go ahead and press sync here and just make sure there's a detection symbol on every QRS complex. Hey, I'm Chris, and this is my RSI preparation checklist OSCE for ILS. We've been called to a 30-year-old male patient who's fallen out of a tree at approximately a height of 4 meters. He's landed on his back and hit his head. On our arrival, we find him lying flat on his back. He has altered LOC. His ABCs are clear. Initial trauma sweep, we find that he has a bobby patch on the back of his head. There's noticeable blood and trauma there. We have a GCS of I score of 4 as it's spontaneous, a verbal score of 2 as he's moaning and groaning, and a motor score of 2 as he is to cerebrate. With this information, we're going to go ahead and call for a backup for RSI. AT1 course control.
AT1, go ahead.
We're requesting an R50 backup please for RSI.
Copy, 10 minutes.
Roger that, we'll go ahead and prepare the RSI.
Thank you.
Endorsed ICP backup en route. We can go ahead and check off the RSI preparation checklist. To do this, I'll get my offsider to read this out to me. I'll go through each component and check it off and relay that information back to him. This is a double checking process to ensure that everything's been ticked off. So Jake, would you be able to please go through the first step?
Attach nasal prongs without oxygen.
Okay. As we're treating a severe TBI, we have a reservoir mask attached. So we'll just detach that briefly and attach our nasal prongs. The reason for the nasal prongs is we want supplementary oxygen, and we also want to prolong desaturation during laryngoscopy when the ETT tube is being placed by the ICP. We then reattach that reservoir mask.
Pre-oxygenate using a reservoir mask at 10 litres per minute or a manual ventilation bag at 10 to 15 litres per minute with PEEP set at a minimum of 5 centimetres of water.
Okay, we're pre-oxygenating with a reservoir mask at 10 litres per minute.
Attach ECG, NIBP and SpO2.
Okay, so we have our 12 lead attached here and we're monitoring the cardiac rhythm. We have our NIBP with our cuff on the arm here, monitoring the blood pressure. We want to maintain a systolic blood pressure of 120 millimeters of mercury as this patient's in severe TBI, and we want to maintain cerebral perfusion pressure. We have our SpO2 probe attached to the finger, and we're monitoring that as well.
Prepare capnography if this is available.
We do have this available. We'll attach that to the ETCO2 and let that calibrate.
Position the monitor so that it can be seen, leaving space to the right side of the patient's head for intubation equipment.
Okay, so the monitor is placed here. It can be seen at the feet, it can be seen on either side of the patient, and it can be seen on the head. On the right here, we've got our equipment moved further enough to the right to allow for the space for the ICP and its intubation role.
Gain IV access, preferably in 2 sites.
Okay, so we have bilateral IV lines placed here at a large bore.
Prepare a running line of 0.9% sodium chloride.
As we're treating severe TBI, we already have the sodium chloride running. That's elevated, allowing for unobstructed flow.
Position the patient for optimal airway control. For example, consider placing a folded towel under the head.
Okay, I have a towel here. Fold that and place that under the patient's head. Allowing for a good sniffing position with ears to chest.
Place an ETT holder with the strap undone under the patient's head.
Okay, got the ETT tube here, hold it here. Placing that under the head and leaving it unattached.
Ensure suction is working and turn it off.
Okay. Turn it on and testing. Okay, that's working and it's turned off.
Prepare a manual ventilation bag with PEEP valve attached if not already in use.
Okay, it's not already in use, but we do have it on the side here ready to go, the oxygen tubing, and our PEEP set to 5 centimeters of water.
Obtain a set of vital signs.
Okay, I'll go ahead and obtain a set of vital signs. I get this information and it comes back as showing a heart rate of 120 beats per minute, a blood pressure of 110/70, whilst we're trying to maintain a systolic BP of 120. We have an SpO2 of 95%, a temperature of 36.7 degrees, a BGL of 7.4. With a patient with an altered level of consciousness, it's important to differentiate this from hypoglycemia. AAE tips is a good mnemonic to do so. We have a rest rate of 10 breaths per minute, and we have a capillary refill time of 3 seconds.
If possible, update the responding ICP with the patient's condition and vital signs.
Okay. AET1 course control.
81, go ahead.
We're just wanting to update you on this patient's status 1, severe TBI, and we just want to give you some vital signs so the ICP backup knows what they're walking into.
Copy, go ahead.
Okay, so we have a heart rate of 120 beats per minute, a BP of 110/70, SpO2 of 95, a temp of 36.7, a BGL of 7.4, a rest rate of 10, and a capillary refill time of 3 seconds.
Copy, I'll pass it on.
Thank you.
Prepare the area.
Okay, so this patient is not in an ambulance, so we're going to clear the area so there's access to both sides of the patient. So we have space here at the feet, we have space on either side between equipment, which isn't cluttered. We have space for our ICP here and his intubation role. If the first attempt of RSI is unsuccessful, either due to being unable to visualize the vocal cords within the first 15 seconds, or being unable to intubate within 30 seconds of laryngoscopy, and a failed intubation drill will need to be adhered to. The endotracheal tube will need to be removed and the patient will need to be manually ventilated using a bag valve mask and positive end expiratory pressure set at 5 centimeters of water. The intubator may elect to reattempt intubation once using a bougie. This will be passed down the trachea between the vocal cords and used as a guide for the ETT. If successful, then the airway assistant may be required to pass the ETT over the bougie and advance it down the airway whilst the intubator holds the laryngoscope and the bougie in place. The intubator may optimize position and visualization of the airway structures by using a different size laryngoscope blade and applying backwards, upwards, rightwards pressure on the patient's larynx. Capnography can then be used to measure end-tidal CO2. If this measures over 5 millimeters of mercury after 2 to 4 breaths, then the post-intubation pathway can be followed. If it measures under this value, then the ETT will need to be removed and an LMA, OPA, or MPA airway adjunct will need to be placed. If the patient can be ventilated using one of these airway adjuncts, then basic airway care can be continued. In a worst case scenario, the patient may need cricothyroidotomy. This is an incision in the cricoid membrane in which the ETT can be placed. Therefore, our options for a failed intubation can be an RSI reattempt, the placement of an LMA, OPA, or MPA airway adjunct, or cricothyroidotomy. Come on, get a countdown.
It's filming already. Give me a thumb.
Fucking cut that one. Fucking you
How
give
did
me
you-
a countdown.
Why?
Yes.
3, 2, 1.
Hi, I'm Chris, and this is my RSI preparation OSCE for ILS.
Oh, hang on. Your head is cut off.
Okay.
Fuck's sake, Martin.